good morning to our speakers from the UK. It's a pleasure to welcome you all to today's webinar on lead poisoning in children. Lead poisoning continues to be one of the most important and unfortunately often under-recognized environmental health risks affecting children worldwide. The effects can be silent, long-lasting, and devastating, which makes awareness, early recognition, and proper management absolutely critical. So today's session is not just relevant, it's essential for all of us involved in child health. We are especially privileged to have with us a globally renowned expert in clinical toxicology who will be sharing her extensive experience and insights on this important topic. Now, it's my great privilege to introduce our distinguished speaker for today. Professor Sally Bradberry is the director of the Birmingham unit of the National Poison Information Service, based at the City Health Campus in Birmingham, in the UK. And Professor Bradberry also serves as the alcohol lead for the Sandwell and West Birmingham NHS Trust, and was instrumental in establishing one of the first hospital-based alcohol care teams in the UK, which is now recognized nationally as a model service. And Professor Bradberry holds honorary academic positions at the University of Birmingham and the University of East Anglia, and is also a visiting professor at the University of South Wales. And she is a fellow of the both European Association of Poison Centers and Clinical Toxicologists and the American Academy of Clinical Toxicologists, and also has served as the president of the Clinical and Translational section of the Society of Toxicology. With over 30 years of experience in managing poison patients, she has published extensively in clinical toxicology and delivered numerous international keynote addresses. Importantly, for today's session, her doctoral research focused on chelation therapy for lead poisoning, making her one of the foremost authorities in the field. And even now, she continues to contribute actively to both clinical care and research, particularly in improving outcomes for patients affected by toxic lead exposures. Professor Bradberry, thank you very much for joining us today despite your very busy schedule, and we are truly honored to have you. And over to you.
Thank you very much, Prof. Dayasiri. In fact, it's lovely to be here. Can you all hear me okay? We're ready to roll. Let me know if there's a problem.
We can very well hear you.
Perfect. Just wave your arms around if there's something going on. Well, thank you for such an extremely kind introduction. I'm sure the weather is better with you than it is here. It's a great privilege for me to be able to share something of my experience from the UK and to try and put some pointers for you as well around lead poisoning in Sri Lanka in children. So let's get going. That introduction just was kind, but certainly made me sound very old, didn't it, I think? Right, let us try, for some reason, there we go. So what I hope to cover with you today is really to start by reminding us why lead poisoning in children matters. We'll look at the sources of exposure. We have to cover something of the toxicokinetics, the mechanisms of toxicity, the features of poisoning one might expect to see, and then management before coming to our conclusions. One of the reasons lead poisoning is so important is that it features as one of the World Health Organization's top 10 chemicals of major public health concern globally. And we can sum up really the problems with lead very simply, because lead is toxic to all body systems. And crucially, it is now widely recognized that there is no safe blood lead concentration for humans. In particular, the developing nervous system is highly susceptible, and that is why children are particularly at risk from lead poisoning. And this is because neurological damage to the developing nervous system is largely irreversible. But there is some good news. The good news is that lead poisoning is preventable. Hurrah. So when it comes to assessing lead poisoning, globally it's recognized that to measure a whole blood lead concentration is the best measure of exposure. But I accept that certainly in many parts of the world, that is not easy. And so we have to use other diagnostic clinical measures. But just a word about blood lead concentration measurement. Always be wary of the units. This is because if you're measuring in molar units compared to mass units, there's a 20-fold factor difference, and this can lead to making errors of judgment when advising on blood lead concentrations. I believe that in Sri Lanka, you mainly concern with blood lead concentrations in micrograms per deciliter. And so for the rest of this talk, I'll just stick to micrograms per deciliter. Otherwise, it gets really confusing. But essentially, blood lead concentrations as low as 0.24 micromoles per litre, but for the units we'll stick with today, as low as 5 micrograms per deciliter, are well recognised as having adverse cognitive effects and potentially permanent neurological damage in children. Indeed, this cut-off concentration, if you like, of 5 micrograms per deciliter has in recent years been reduced to 3 micrograms per deciliter being the indicator value for concern. And as I've already said, to some extent, we should be saying that no detectable blood lead concentration is acceptable in children. The problem with that is that you actually don't see manifestations or features of poisoning until the blood lead concentration is considerably higher than that which can cause damage. Indeed, of an order of nearly 10-fold higher than that toxic value, if you will. So that we typically do not see features of poisoning until a blood lead concentration is of the order of 30 micrograms per deciliter. This global map shows mean blood lead concentrations in children under the age of 19 years. And you can see that we should be sort of aiming for something around 0 to 1 micrograms per deciliter, but it only seems that Finland and 1 or 2 other parts of the world managed to achieve such low blood lead concentrations. In Sri Lanka, you're sitting somewhere sort of in the middle, if you will, with a mean blood lead concentration for children at the age of 0 to 19 of 3.7 micrograms per deciliter. And it's been estimated that there are about 1.2 million children in Sri Lanka with a blood lead concentration greater than 5 micrograms per deciliter. So there's work to do, as there is all over the world. Probably the most important part of this talk is to just be aware of the potential sources of exposure so that we think about them. And I've already said that children with a developing nervous system are particularly at risk, and even more so children who are crawling and have increasing hand-mouth activity. So they're exploring their environment and putting themselves at risk of the various sources of exposure we'll talk about. Wherever there's industrial activity that may handle lead or produce lead, that will put potentially lead contamination into the atmosphere. But also, very importantly, in terms of lead exposure for children, lead can contaminate soil. And this can be important for all children, but particularly children with pica. We also have to think that where there are occupational sources of lead exposure, that parents or other family members may bring lead dust home on their clothing, and this can be an important source of lead exposure for children also. One of the most important sources of lead exposure now widely recognised is paint. In many parts of the world, lead-based paint has been banned to be used in indoor paints, but lead is still allowed to be a component of paint in outdoor paints. And children may encounter this, as in this illustration, in various outdoor structures. And if that paint is old and peeling, then it's a potential risk for ingestion, again, particularly for children with pica. But also older properties will still have indoor paint that contains lead. This is a picture from the UK. And maybe if there is reconstruction or redecoration in a property, then parents may expose their children inadvertently to lead dust during that process. This is a photograph of a domestic property in the UK where a child lived with neurodevelopmental delay and autism and had very marked pica. And you can see here the paint and the plaster work that has been gradually, the child has gradually been picking away at this plaster and ingesting it, and both the paint and the plaster were heavily contaminated with lead, and the cause in this case of lead poisoning in this child. So we should always think about lead poisoning in children with pica. Other potential sources of lead include traditional remedies and medicines. And I'll just share with you a couple of cases of young people I've looked after over the last few years with lead poisoning from this source. This, on the left here, this slide shows some medicines that one of my I don't often do paediatrics, I should say, but I do get to consult on children with lead poisoning, which is a great pleasure. These medicines that you can see in the picture were prescribed to a young man who traveled to visit his grandparents in Asia, and he was prescribed these medicines to allegedly cure his eczema, which sadly it did not do, but the sort of pale brown dust that you can see in that second pot was heavily contaminated with lead, and he was eating spoonfuls of this every day. And when he came back to the UK at the end of the school holidays, he had quite marked lead poisoning. This is very blown up image, but this was a sort of lump of lead that was about 2 centimeters in diameter, that another one of my patients was advised by his grandma he should suck on for 2 hours a day in order to cure his speech impediment. Sadly, that didn't work either. Other potential sources of lead poisoning are in ceramics, if the glaze contains lead, or sometimes lead can be a contaminant of spices. But we've, particularly in the UK recently, had problems in fairly large stores that have been bringing turmeric that has been contaminated with lead, and that has been a source of lead exposure to adults and children alike. Toys can potentially be contaminated with lead if the paint or dyes that are used in them are not appropriately controlled for their lead concentration. And finally, we have to mention the potential of lead contamination in drinking water. And I think many people would think of drinking water as the initial source of lead poisoning, but certainly in the UK, this is pretty rare now. Certainly, yes, lead can be a source of poisoning if individuals have lead-based piping, but even in that scenario, once the tap has been run for a few minutes, the flowing water then usually has a relatively low lead concentration. So there's a lot of different potential sources for us to think about. Lead can be absorbed by ingestion or inhalation, and lead is particularly well absorbed by children, considerably more so than it is in adults. Uptake into the gastrointestinal tract of lead is both passive and active, and the active transporters of the bivalent lead ion are shared by iron and calcium. And it's for that reason that children who are iron or calcium deficient are more susceptible to lead poisoning, because they have increased gastrointestinal uptake of lead. Now, this, I'm going to now show you an illustration just demonstrating to us the importance of understanding lead distribution. Following ingestion or inhalation, lead is obviously absorbed into the bloodstream, and from there into two compartments we could loosely describe as the soft tissue compartment down the liver and kidneys at the bottom, and importantly up the skeletal compartment on the right hand side. The main means by which we eliminate lead is via the kidneys. Now, there is, of course, a degree of equilibration between the blood compartment, the soft tissue compartment, and the bone compartment, with lead moving backwards and forwards all the time. But in a steady state, you can, if you like, consider that we have three compartments for lead: the vascular compartment, the soft tissue compartment, and the bone compartment. And note here that nearly all of the body burden of lead in a steady state is in the bone. And that's because lead replaces calcium in our skeleton. Now, that lead sitting in the bone is there for a pretty long time. That we've got a half-life of anything between 3 months and 20 years, depending on the type of bone. And that's why it's so important to prevent lead poisoning, because once lead is in the skeleton, it's pretty much there forever. Now, it's fair to say that lead in bone is actually relatively inert. It's not the lead in bone that is causing health problems to children and adults alike. It's in fact this tiny little bit of lead. If you see that in the vascular compartment, only about 1% of the total body burden of lead is sitting in the vascular compartment, and only a very small amount is existing as free lead ions. But it's that free lead ion that causes most of the symptoms of lead poisoning. But of course, having this bone burden is still important, because as it will continually top up that little bit of free lead in the blood and cause symptoms. When it comes to the mechanisms of lead poisoning, I've already mentioned that lead is toxic to all body systems, and that's because it can complex with so many important functional groups, carboxyl groups, amino groups, sulfhydryl groups, and therefore can disrupt the function of many key enzymes. If you like, a second main mechanism of lead poisoning is that lead can substitute for calcium and to some extent zinc, giving potential for widespread chemical interactions at cell membranes and various intracellular organelles. Let's look at a couple of examples of lead affecting enzyme activity. This probably fills all of you with some degree of dread if you recall the days at medical school trying to memorize this diagram. That is basically summarizing how we make heme, starting the top left-hand corner here with succinyl-CoA and glycine, following the process round to the production of heme to then make hemoglobin. You can see that I've highlighted here 3 points in this pathway where lead inhibits key enzymes of heme synthesis. And by far the most important one is at the top there, lead inhibiting aminolevulinic acid. Let's call that ALA for now, ALA dehydratase. Inhibition of ALA dehydratase, which is blocking the conversion of ALA to porphobilinogen. And that means that ALA accumulates. And we now know that because ALA mimics structurally GABA, part of this ALA accumulation can explain the lead neurotoxicity via mimicking, if you will, GABA receptors. So that explains the key mechanism by which lead causes anemia. But lead also inhibits another key enzyme in red cells, erythrocyte pyrimidine 5' nucleotidase. That's another mouthful. We'll try to avoid saying that again. But accumulation of nucleotides in immature red cells as a result of inhibition of this enzyme causes damage to red cell membranes so that red cells are prematurely destroyed by the spleen. And also we get accumulation of the nucleotides in red cells, causing what we recognize as basophilic stippling. So these are two mechanisms, disruption of heme synthesis and early destruction of red cells, explaining why anemia is a manifestation of lead poisoning. We said that our second key mechanism of lead toxicity is substitution of calcium and to some extent also for zinc. And you don't have to think too long to see how lead substituting for calcium can be quite devastating. Through inhibition of key enzymes like calcium ATPase, impairing calcium-dependent neuronal differentiation, synapse development and function, therein sits the problem for a developing nervous system in a child and the problems that lead toxicity can cause. The developing brain being particularly susceptible, potential disruption of calcium-dependent second messengers. Hello, I think somebody's joining in. Welcome. And we may also see acute calcium-mediated cell death. I think it's Yuma Fernando who we can hear, but
please mute yourselves. Please mute yourselves.
I'll try and speak over them. No worries. Please, everybody, could you just check that you're on mute? Otherwise, we'll all be joining in the conversation globally. I don't know if I can mute. Can I?
Please mute yourselves. Please mute yourselves, everybody.
Oh, there you go. Lovely, lovely. Thank you, Kavinda. Thank you. Now, we must remember that I said right back at the beginning that one of the problems about identifying lead poisoning is that features are not present until concentrations that are far higher than those we know are causing problems. So we're almost doomed to diagnosing lead poisoning at a late stage when damage has already occurred. But the kind of symptoms that we're looking at, and again, this is lead concentrations around 30 micrograms per deciliter, compared to that concentration at which we know problems begin around 3 micrograms per deciliter. And we may see anemia, as I've already alluded to, the mechanisms of anemia. Often more common as an early presenting feature will be the gastrointestinal features of lead poisoning, with more frequent of colicky, pain, constipation, failure to thrive. Nausea and vomiting are less common than the aforementioned gastrointestinal features. Central neurological features are a problem because they may be difficult to identify, rather vague, headache or just generalized reduced activity or alertness. And these things, again, not occurring until blood lead concentration is of the order of 30 micrograms per deciliter. At much higher lead concentrations, around 100 micrograms per deciliter, you may see much more severe central neurological effects with cerebral edema, encephalopathy, and seizures. You can also have peripheral neurological damage. I've put there motor and sensory neuropathy at 30 micrograms per deciliter, but we now know you can get more subtle subclinical effects on nerve conduction at much lower lead concentrations. So by far and away, the most important message of this talk is that if we're going to improve our diagnosis and management of lead poisoning, we have to think of the diagnosis in the first place. And if possible, that would also include then measuring the blood lead concentration to confirm. There may be a role for X-rays in chronic lead exposure because lead deposits at the growth plate, and you may see a thickened growth plate in long bones as a diagnostic feature of lead poisoning in the chronic setting. In the more acute setting, because lead is radio-opaque, it's possible to see on X-ray lead-containing foreign bodies, and that could include flecks of lead-based paint if ingested in significant quantities. The big thing about improving the situation for children is to identify their source of lead exposure, and we've talked about various potential sources. I must say that it's certainly not always easy to identify the source of lead poisoning, and to some extent the clinician has to become something of a detective, working with colleagues in community medicine and community practice to ask appropriate questions, to really drill down to the various sources that we talked about earlier, thinking about take-home exposure, thinking about where the child is going maybe for daycare or for school, thinking about travel they may have undertaken, medicines they may be being given by family members that are not prescribed, etc. It's having in your mind these things that is going to be the key to a better identification of lead poisoning. Now, to give you a feel for what we do in the UK, really, our management strategy is largely based on the blood lead concentration. And measuring blood lead is part of the differential diagnostic package in any child with pica and any child with developmental delay, or where there's a suspicion that there could have been an exposure. And a blood lead concentration greater than 2 micrograms per deciliter is considered a trigger for us to go and look for an abnormal or unacceptable, if you will, source of lead exposure in that child. And blood lead concentrations above 5 micrograms per deciliter in the UK constitute a value that it is compulsory to report to health protection, so that that source of exposure is identified. Well, that's easier said than done, but at least somebody looks for it in the child and is removed. And then you see there's quite a jump. We're not really advocating chelation therapy, treatment to try and enhance lead clearance until much higher blood lead concentrations. And that's partly because children don't come to attention until much higher concentrations for the reasons I've explained about symptoms and the concentrations at which symptoms occur. But this also demonstrates that chelation therapy is absolutely not the answer. The answer in most cases is identification of the source and removal of that source. But we must say something about chelation therapy because it certainly has a role in the management of severe lead poisoning. So the principle of chelation therapy is that you've got a metal ion bound to an in vivo binding site causing damage. And in the presence of the chelating agent has a much higher affinity for lead than does the binding site in the body. And therefore, the chelating agent pulls the lead off the binding site. You have a metal chelating agent complex that is then predominantly renally eliminated. So we have a couple of chelating agents that we use in the UK, Suxma and sodium calcium-meditate. They both reduce blood lead concentrations really effectively and increase urine lead clearance. And to that extent, they both can rapidly resolve the symptoms of moderate or severe lead toxicity. Suxma, DMSA, dimecaptosuccinate, has the advantage that it can be given orally, while sodium calcium-meditate is preferred in the presence of encephalopathy. In fact, adverse effects of chelation are rare. One of the things you have to be careful about is that these chelating agents are pretty good at binding and removing other metals, including essential trace metals, particularly copper and zinc. And so, I don't know if that was me or somebody else drawing on the screen, but it's very pretty. But it's possible to cause zinc or copper deficiency, particularly if you're giving chelating agents when the blood lead concentration is low. The most common adverse effect of Suxma is an increase in the transaminase activities, ALT, AST, but this is usually reversible when the Suxma stops and rarely is a reason to stop treatment. Sodium calcium-meditate's main risk is that you have to be careful in the presence of renal impairment, and it's relatively contraindicated in those circumstances. Of course, the biggest downside with chelating agents is that they may not reverse toxicity because, as I've already mentioned, particularly in children exposed to lead during the time when their nervous system is developing, that damage can be irreversible, and chelation therapy can make... Was that me? Should I try and remove it? Oh, no, don't worry. Sorry about my little scribbles. Maybe I'm just reminding you of the importance of children, showing them in this context. So chelation therapy is definitely indicated in children who have lead encephalopathy. And we would also consider its use in children with blood lead concentrations above 45, 50 micrograms per deciliter if there are problematic symptoms. But I cannot emphasize enough that chelation does not offer neurodevelopmental improvement in young children with blood lead concentrations under 45 micrograms per deciliter. And it's for that reason that prevention is so much more important than cure. The decisions around chelation therapy involve consideration of the blood lead concentration, as we've said, also of the symptoms, and of the duration and severity of exposure. And in particular, whether or not the source has been identified and removed. There's no point chelating a child with a moderately high blood lead concentration if you're continuing to expose that child to lead. Now, you'll recall this diagram summarizing lead redistribution. And remember that when we give a chelating agent, the point of giving that chelating agent and treatment is to enhance the renal clearance of lead. And in so doing, we will empty, if you like, empty the vascular compartment of lead as the chelating agent binds the lead. But remember that as we shift that equilibrium and empty the vascular compartment of lead, so if the child has been exposed to lead for a long time and has a significant bone lead store, their vascular compartment and soft tissue compartments of lead will just be topped up, if you will, from their bone compartment. And so for that reason, in chronic exposures, the blood lead concentration will rebound following a few days of chelation therapy. And therefore, chelation therapy is typically given in short courses, something like 5 to 7 days, where we'll see the blood lead concentration dramatically fall, maybe even to being undetectable. But then we will break treatment for a few days, 5, 7, sometimes 10 days, to allow for redistribution of lead from the bone to the blood before we subsequently give it another course of chelation therapy. The response to chelation therapy is best monitored by a combination of looking at the blood lead concentration, but also urine lead clearance, combined, of course, importantly with clinical review and responsive symptoms. Expert advice is usually available for clinicians and colleagues who have a particular interest in lead poisoning, and I would always be very happy to receive email queries regarding lead poisoning management, should that be helpful. So, in conclusion, there is no safe level of lead exposure in children. Lead poisoning is preventable, but it requires us to be aware of the risk, to have some degree of diagnostic capability and knowledge, and then to be very proactive, particularly about identifying and removing the source of exposure. Chelation therapy does have a role, and certainly it saves lives for children with lead encephalopathy, but ultimately preventing exposure is the priority. Thank you very much. This is a picture of me in 1969 on Bournemouth Beach. And thank you, just to close with, so I didn't look, unfortunately, lead poisoned at that stage, nor since, I hope. Thank you very much.
Thank you very much, Prof. Sally Bradberry, for that excellent and very informative lecture on lead poisoning in children.